Newborn screening helps families to have healthy babies. Infants with newborn screening disorders don't show any physical signs or symptoms of disease generally in the first few days of life, but by testing blood from a heel prick, we're able to detect over 40 different kinds of genetic disorders that are serious but treatable.
We depend on newborn screening. I went from being a pediatrician at a time where sickle cell disease was a disaster because we never knew who might have it, leading to crises that would present in the emergency room, workups that often would go uninformed and result in poor outcomes. The newborn screening has dramatically changed the lookout for that child and for the family. We now can identify and intervene in ways that we never could before.
And newborn screening happens on the second day of life, where the heel is pricked with a little needle, then blood is dripped on a filter paper, and once dried, that dried blood spot sample is sent to a screening laboratory. The RUSP, which is an abbreviation for Recommended Uniform Screening Panel, is a group of conditions that the U.S. Secretary of Health and Human Services recommends that every baby should be screened for. A technology called tandem mass spectrometry allows to look for many different biomarkers in the dried blood spot in just under 2 minutes. And those biomarkers can indicate various numbers of conditions where this early identification and diagnosis of the disease will allow treatment, which then can prevent mortality, morbidity, and disabilities.
Newborn screening is just that, a screening test. It is not diagnostic. So the goal of newborn screening is to pick up all of the babies with disease. But to do that, sometimes babies are detected who do not have disease. False positive newborn screens have a significant negative impact on families. This not only has financial ramifications for families, but also psychological ones. It causes emotional stress and worry and over-medicalization when these families have to bring in their newborns for additional testing when the child doesn't really have a disease.
When we have high rates of false positives, we create complacency. Newborn screening will look like a burden on the community rather than this incredible, miraculous technology. And so we've got to guard against false positive rates.
What we have come up with over the years is refinements to newborn screening, where we use the existing blood spot sample that we receive for primary screening, and we take another blood spot punch and do a more specific analysis for the condition that the baby may be affected with. Another tool that we have developed in the laboratory, and specifically Dr. Piero Rinaldo, is a bioinformatics tool to look at all of the newborn screening data, not only the results that come from a single test, but also all the other tests and additional covariates that are included in the screening card, such as the birth weight, the gender of the baby, the gestational age, the age at collection, all kinds of things that might help us to better define a specific metabolite profile that would be either fall more with the true positive and affected population versus the healthy population. We assume that newborn screening is going to further expand. More conditions are being proposed for newborn screening on a regular basis. We are continuously looking at what is coming, what should be coming, and see if there's a test that can be done at fairly low cost and high throughput to meet the requirements of newborn screening.
I've had a number of children recently born over the last 4 or 5 years who have grown remarkably and developed normally on time, all because of our newborn screening program. The miracles of newborn screening are amazing.